A Esperanza Naredo é uma reumatologista académica e clínica que trabalha neste momento no Hospital Universitario Fundación Jiménez Díaz em Madrid e que veio cá também para assistir a biópsias connosco. Portanto, isto é uma win-win situation que nós aqui criamos. E passo então a palavra e obrigado. Thank you, Esperanza. You may start. Let me just...
Bom dia.
It's like this. Some technical difficulties. Okay.
And this?
Yeah, you can put in my pocket.
Well, too high? So, bon dia, good morning to everybody. Thank you very much for this kind invitation. I was here in this one with you for sharing and for learning from these two people and other colleagues, of course. And I'm very happy you are here in this lecture. This is an interactive lecture. Please, you can stop me whenever you want to discuss, to be in favor, against. Do you agree? Yeah? So, how to come? Yeah? I have to do it? Oh. No, because it's a little complicated. So, right, I will try. Well, we'll try. So, if not, I will take the control. Okay, so the topic of the lecture is this, MSK, musculo-skeletal injections. Conventional, what is conventional? The classical. Versus imaging-guided, particularly ultrasound-guided injections. My question for you, for all of you, are you performing MSK injections routinely? How many people are injecting MSK? Only 2. I don't say under ultrasound guidance in general, MSK injections or joints. No? You are not injecting anything in life? It's a pity. Okay, so I will do my best to cover all the aspects. So you are not MSK specialist, rheumatologist, but you are not injecting anything. Okay, you will inject from Monday morning, you'll see. So the topic is conventional, so classical, versus ultrasound-guided injection. Next, please. I don't have any conflict of interest related to this topic. Next. And this is the agenda. Very briefly, we will go through these different points. Okay? I think I have 40 minutes. I will ask for 41 minutes, and then we have 20 minutes for 19 minutes for discussion. Okay? So just very briefly, this is general, applicable to injection in general. Next, please. We have a lot of indication for MSK injections. We are just focusing on musculo-skeletal injections. And then I have put in this side the most controversial for this topic, conventional versus guided, ultrasound-guided. For example, we are using this for aspiration of fluid, either intraarticular or extraarticular, mainly for diagnostic purposes, for ruling out infections, for ruling out microcrystal diseases or other diseases, right? Then we are using for intraarticular medication in different diseases, inflammatory arthritis, osteoarthritis, microcrystalline, and also for what we call regional pain syndromes or soft tissue syndromes, no? Very extraarticular medication injections for tenosynovitis, bursitis, gangliasis, enthesis, a lot of structural, anatomical structure, a lot of indications that can be inflammatory or can be pure mechanical. For example, trigger finger. So all these pathologies can be treated with these local injections. Next, please. And this is when I am focusing my lecture, because no time for all, and also because the other main indications, such as spine injections, sacroiliac injections. Are you performing spine injections? Anyone? Here? No? Perineural injections or nerve blocks, synovial orthosis, or any type of biopsy, including obviously this center is reference in the world for synovial biopsy, but not only synovial, I mean soft tissue masses, whatever. So next, please. Because I think I am not focusing on this because I think these indications should be, maybe you agree with me, everybody agrees on, should be guided by imaging. Next. Not necessarily ultrasound, can be fluoroscopy. So these injections are always guided by imaging. But the controversial topic is the others. Okay, next. What injectable medications? Well, in rheumatology we use a lot corticosteroids, but there are others, no? Local anesthetic, hyaluronate, prolotherapy, botulinum toxin, stem cells, platelet-rich plasma. I don't know. I wonder if you are using other of the or some of these medications. Is there any sport doctor here, sport medicine doctor here, or you are practicing sport medicine? So they are injecting a lot of platelet-rich plasma or stem cells. Oh, the rehabilitation, that's right. In my hospital too, they are using and increasingly using this. Prolotherapy, botulinum, neurologists use a lot, but not only for this muscular dystrophic. So you see the literature of all these products. The evidence is not so huge. It's not so huge. However, the majority of doctors dedicated or focusing on musculo-skeletal system, either rheumatologists, orthopedics, rehabilitation, sport medicine, are using these products with successful. So we are happy with this. Because of that, we are using that, no? So if the patient is complaining, we won't use, no? So, however, we have to admit that the evidence on that is not so strong. Doesn't mean that they are not working well. I only say that the evidence is not so strong, including corticosteroids. Huh? Next. So, just a few words about, we'll say, conventional, or really what is more, I say correct, is external landmark or anatomical landmark guided injection. No? Okay. Next, please. So more or less 10 years ago, I had the privilege to be invited by Juan Canoso. Probably you know him. Juan Canoso is absolutely pioneer in anatomy, applied to clinical issue in soft tissue diseases or regional pain syndromes. He's living now a long time ago in Mexico. He's from Chile. He was living in the United States for many years. And this professor invited me to collaborate in this book that you possibly know very well, Rheumatology, the Hopberg. And he offered me to write with him this chapter. And obviously I accepted very, very honored. I accepted very honored first because I admire Juan Canoso. For me, he's a mentor. And there is a second reason. You can guess which reason. Because before that, this chapter was absolutely pure conventional guided injection. And then I say, Juan, thank you very much. I will collaborate, but it's time to include in the chapter ultrasound-guided injection. And he said, of course. And then, for the first time 10 years ago, and now increasingly in this chapter, there are more and more and more on ultrasound-guided injection, obviously because I am an ultrasonographer people. So after a few years, Juan Canoso left because he's retired, and then we are collaborating this chapter, myself and my colleague and friend Ingrid Moller. Next. So these are images from the chapter. many images on how to inject, indicating the approach for, can you see? For each joint according to the indication. No? If you go to the book, you will find these images. Next, please. Or this. However, every 2 years we update the edition, and I have to tell you that the conventional are going fewer, and the ultrasound are going more. So it's a balance, depending on the location, the indication. Next, please. So what we know is these external landmark guided injection are based, next please, on the knowledge of anatomy, obviously. You have to know the anatomy, and because of that, these approaches are established, no, according to the anatomy. Next. And, yeah, next. So you need anatomy knowledge, training, and expertise. And with that, you will perform conventional or classical injections very successfully, I'm sure. Without damaging the patient will be very happy. Sometimes they are working better, sometimes no. As I said before, the evidence is not so strong. Sometimes it's placebo effect, maybe, who knows? No? I mean, we don't know everything in medicine. However, I consider all MSK specialists totally able to inject by this anatomical landmark every joint, at least peripheral joints. I wouldn't say that in the spine is so the same, no? Do you agree, doctor? Totally? Okay. Next. Then a few words about ultrasound-guided injections. Next, please. Well, the rationale, why to use that? No? Arguments. Next, please. We can, with ultrasound, we can confirm the clinical diagnosis and the indication. So you want to inject something because something, an indication, because there is fluid, because there is inflammation, because there is a tendinosis, because there is whatever. So for that, you need to have a diagnosis before. Then you can have the clinical diagnosis alone, that is okay, or you can complement this with an imaging diagnosis. Then you can send to the MRI department the patients and wait in the report, and then decide, okay, I will inject. This is option A. And option B is at the same time, I do the diagnosis with this hand, I inject with this other. What do you prefer? If you are a radiologist, will say MRI, obviously, no? Okay. So this is the reality. I do the diagnosis at the same time I decide the indication and then I inject. I don't need to wait anything else. So this is a good reason for doing. Next, please. Selection the target structure. I'm sure anyone is injecting the shoulder here, no? I need a voluntary. You? Yeah. When you are injecting the shoulder, because you have a painful shoulder, in abduction, blah, blah, what do you inject? Tell me an example. Yeah. But how do you know that there is bursitis? No, so you are not my I would like to have someone not performing ultrasound. Anyone not performing ultrasound? Well, you are not performing ultrasound. So I have a painful shoulder when I do this impeachment, blah, blah.
Well, clinically it can be quite similar. Patients may have pathology that first may have several pathologies that cause pain, may have findings that may cause clinic symptoms, and sometimes the clinic is very overlapping.
Sorry, I fully agree.
And that's why I think we should have some form of imaging.
For sure, but you are not in the, I mean, you are in our side. No, this is not a fighting, it's just a pure enjoying and making science. But in my department, for example, people not using ultrasound, when I ask this question, they say, I'm injecting subacromial. Subacromially. And I say, subacromially, you have the subdeltoid bursa, you have the maybe the supraspinatus tendon, if there is, because maybe there is a rupture. What else? You have the subscapularis, posteriorly the infraspinatus. What structure you want to inject? What structure? What are you talking about? It's just to put subacromial. So what I mean is that people are not thinking on what target they want to reach. And maybe this is not important, who knows, but maybe it's important. So with ultrasound, you decide what target you will direct your needle, just to aspirate or to put a medication. Without ultrasound, it's really hard. Next, please. Well, you will have information, ultrasound is providing us with information to plan the best access to the fluid. So I want to aspirate fluid for diagnostic purposes. I will see the fluid, I can distinguish this fluid from other things, solid tissue. Then I will direct the needle, I will put the needle in the fluid. So, because if I put the needle in the solid tissue, I won't have fluid. And this happens many times in conventional, no? They are aspirating the knee and say suddenly, oh, no fluid, no more fluid, and you see. Why? Because the needle has moved and is not inside the fluid at this moment. It's maybe in a solid tissue, synovial hypertrophy, or it's outside. And then this never happened with ultrasound because you see the needle. Next, please. Then you have information for selecting the appropriate length of the needle, because you know what is the target and you know what is the skin. So you take the measurement and then I need an intramuscular, I need a longer needle. Sometimes it happens in conventional, you are trying to, and then you are not reaching the target because it's too short. This is obvious in ultrasound, it's so easy. Next. And minimizing risk of damaging some sensitive structures that can be very close to the target. For example, vessels, tendons, nerves. Why? Because using the conventional approach based on anatomy, we know that the safer routes are trying to avoid these structures. But there are a lot of variants, anatomical variants, and you never know. And the nerves can be by feet, or so with ultrasound you see the structure. It's not that you have to imagine the structure, you see the structure. So apparently better. Next, please. And the other rationale for doing that is that you will be able to see the delivery of the medication. Next. So, physics are basic, very, very simple. We are able to guide injections with ultrasound because we see the needles. Next. Either when we are parallel to the transducer as a line, a white line, hyper-reflective line, or, next please, when we are perpendicular, we will see the tip of the needle as a hyperechoic, hyper-reflective or hyperechoic spot. Next. And the size of the needle does not influence the visualization, right? So this is good. Next. Some examples. I don't know if you are used to people who are not using ultrasound. Can I point out from? So this is a phantom, and now the needle is parallel to the long axis of the transducer. It's a mechanical, painful shoulder, and I just distending the bursa with corticosteroids as anesthetic. Yes, for improving clinically the patient. No? It is nothing to do. This is pure inflammation. This is just mechanical fluid in impeachment and rotator cuff disease, but still, I decide to inject the patients to try improve. And then this is the first extensor compartment of the wrist, the typical Dicker vein disease. No? So I inject it, you can see the needle here, and then the drug is, in this case, both tendons are with a common synovial sheath. You know that this is different according to the people, no? Can have a lot of anatomical variants, can have two different synovial sheaths or the same for both, as in this case. So I am checking that the drug is in the correct, or at least in the correct, I don't know, but in the planet location. Or this retrocalcaneal bursa in an spori. I am just touching the tendon. Careful, don't touch the tendon. It's because it's dangerous, no? So it's painful. You have to not to touch the tendons, the nerve, the vessels. And then you have the control, or these are the peroneal tendons in the ankle. I am kissing, you see? I'm kissing the tendon. No, I don't want to touch you, Mr. Tendon. I will avoid you because you are a sensitive structure. So what I mean is that you will have the control. You see inside the patient and you will have the control. Or this olecranon bursa, that seems very easy clinically because it's very obvious, no? However, as soon as you are aspirating fluid, you are moving. Then, I'm touching the periosteum. See, I'm kissing the periosteum because of that. The patient says, I have pain. Then I know why. Because I have moved as I am aspirating, then I can move and touch sensitive structure, for example, the bone. That is not dangerous but very painful. Including the knee. The knee is possibly the easiest joint for conventional injections. However, I see where I am. I am aspirating fluid in this is an osteoarthritis, I'm aspirating fluid. And I want to see that my needle is inside the joint to be sure that I am injecting the steroid inside the joint. Why? Because what's my plan? My plan was to put corticosteroids inside the joint, not in other location. So I am fulfilling my plan. Distal radio-ulnar joint in a rheumatoid arthritis, you see how beautiful the steroid is delivering. It's going to the joint, no? The joint is here, in between the two bones. So you see the delivery of the drug. And for example, this finger flexor tendon, I'm going through this approach. Why? Because I have a very sensitive structure there. So this is the digital nerve and vessel. If I go in this way, possibly I will touch the nerve. So I will produce pain and mainly damage. So I will go in the opposite side, and then in this particular case, at this particular location, much more safe. So obviously you need a training on that. When, for example, according to the Euler courses on ultrasound that many of you possibly have attended or will attend, and according to the EFSU, EFSU is the European Federation on Ultrasound in Medicine and Biology, we recommend always to start with this training after the intermediate level, or better in the advanced level. So what I mean is that you need previous knowledge on ultrasound for performing ultrasound-guided injection. We start always with animal models, with phantoms, usually at the beginning animal models. We can use also jelly, we can use specimens, but the most commonly used for training, and it's very, very brief if you know how to perform ultrasound, is just to put olives inside. This is the image of an olive, it's beautiful. And then you can train your ability, your skills with both hands, the probe and the needle, very, very easily and very briefly. So preliminarily, what can be the pros and cons of conventional versus ultrasound-guided injection? Well, we can say for conventional or external landmark injection, they are rapid, they are relatively easy. Obviously, you need a train before, but they are inexpensive, very cheap, well accepted by patients for sure. And cons, for me, the main cons is that you don't see the needle. So you see the needle outside, but you don't see the needle inside. Then I wonder, is the same that saying blind? Somehow, maybe it's a little blind. And because of that, I wonder if in all patients are really absolutely safe. For ultrasound-guided injection, pros, the most important, you see the needle. You will be able to visualize the needle from the beginning to the target. They are relatively rapid. possibly a little less than conventional, but still rapid, easy, if you know how to perform ultrasound, obviously. Relatively inexpensive. Well, the price is the same. The problem is that you need the ultrasound system. So, well accepted by patient. Usually, when you ask patients to compare, they prefer under ultrasound guidance. The cons, obviously, you need an ultrasound training. You need to know to be able to diagnose with ultrasound, and you need the ultrasound scanner. And preferably, it's better with other people helping you. So, can be a disadvantage. Just a few words on the implementation of both conventional and ultrasound-guided injection. This paper that was part of a Euler task we performed around 4 years ago was a survey that was sent to both patients and health professional care providers. I was part of this Euler task that I will show you later on. So the surveys were answered by 200 patients and 186 health professionals from 26 Euler countries. As you can see in this table, most were performed by rheumatologists, but also for other specialists such as orthopedic surgeons, general practitioners, sport medicine specialists, radiologists, obviously. So a long list of pain specialists. So rheumatologists are not the only one who are using, we are talking about injection in general, not necessarily imaging guided. The most frequent indication according to this survey, arthritis, inflammatory arthritis, osteoarthritis, crystal arthritis, and bursitis, as expected, no? And the joints more frequently injected the knee and the shoulder. And then this is very interesting, when we ask particularly for the use of ultrasound as a guidance for injections, you see that 22% of the health professional who answer never use ultrasound, 50% sometimes, and only 4% or 2%, sorry, always. And one interesting comment was that ultrasound should be used to help difficult injections. So most of the surveyed people say, well, I use ultrasound when the injection is difficult. I don't use when the injection is easy. The question for me, and I ask you too, is how do we define what is a difficult injection and what is an easy injection? So, of course, in very deep areas, it's more difficult. But you never know if it is difficult or no until you don't see what is inside the patient, in my modest opinion. Then when we asked the patient, we had these answers. I am copy and paste. This is in the original paper. So many patients had no experience on ultrasound-guided injections, but in those who had tried both, you can see prefer to have ultrasound guidance. Why? Well, they say this interesting comment that I don't agree, but anyway, it was the patient opinion. Some patients suggested that the use of ultrasound to help guide of intraarticular injection may be associated with the doctor injection skill. So if you are very skilled, you don't need ultrasound. If you are not so skilled, you use ultrasound. That I don't think is true, no? But this is the perception of the patient. Yeah, why not? I mean, we ask, and that's all. And then, just focusing on ultrasound-guided injection, we did this survey a long time ago, was published in 2011, among the Euler countries. And just to show you very briefly the results. So this figure is in the percentage of rheumatologists, now we are talking about rheumatologists, performing in general injection or ultrasound-guided injection. So you can see that general injection, this black, more than 80% of rheumatologists were performing conventional injection in most countries. Obviously, we know that rheumatologists are performing this across Europe and all over the world. However, when we focus on ultrasound-guided injection, this one, you can see the percentage. So less than 10% of rheumatologists were performing ultrasound-guided injection in most countries, so a minority. We ask also the most frequently injected joints with ultrasound guidance, the shoulder, the ankle, the knee, you can see this. And the percentage of rheumatologists receiving training, particular training for that, as you see, less than 10% in most countries, more than 80% in no countries at this moment. After that, we repeat the survey 3 years ago, so just before the pandemic, following more or less the same methodology, EULAR countries, European, because this was under the umbrella of EULAR. And the things have improved a lot, but still we need more training on that. You can see here, this is 40-60, so 50, more or less 50% of the rheumatologists are using, in this case we ask for imaging in general, not necessarily ultrasound. So, more or less half of rheumatologists performing injection under imaging guidance. You can see that it's not so bad. This is blue, Spain, Portugal is not, you have more, no? Yeah, France, okay. Patient, no, you have less, according to this survey. 10 to 20% only using ultrasound guidance. This color is including Portugal, Ireland, so summarizing that, there are more rheumatologists, this is only rheumatologists, performing ultrasound guidance or imaging guided injection that in 10 years before, but still is a minority in comparison with the rheumatologists performing ultrasound. The joints, the most commonly injected joints with ultrasound guidance were more or less the same that 10 years ago, so shoulder, knee. And then we move to the to the main topic of the lecture. I have selected these 3 papers because no time for going two more. The EULAR recommendations we produced 3 years ago, published in 2021, so 1 year ago. But these are in general on intra-articular therapies and the corresponding systematic literature review. These EULAR points to consider for the use of imaging to guide interventional procedures in patients with rheumatic MSK diseases. These were published 1 year ago, less than 1 year ago, with the corresponding systematic review. And this EFSUM is the European Federation of Societies for Ultrasound, and we work very closely in both. And we produce under this umbrella also some recommendation on this, on the use of ultrasound injection, and these were published also in 2021. So you will see that the results are different, but all of them interesting. So looking at this recommendation in general or intra-articular therapies, this was our main conclusion of the systematic literature review linked to the, you know that the EULAR task always we have to perform a systematic review, and after that we produce recommendation of point to consider is when there is no strong evidence. So this was the main conclusion. Several published systematic literature review report that ultrasound improves accuracy in delivery intra-articular therapy, although clinical outcomes are similar to those of conventional injection. So, more accuracy, for sure, but the same efficacy or effectiveness. This was the main conclusion of our systematic literature review on that. Now going to this other EULAR task. So they were more or less going parallel, but they were different. That I told before, EULAR points to consider because there is no enough evidence to call this recommendation on the use of imaging to guide MSK injection, and the linked, because it's mandatory to perform a previous systematic literature review. Just to show you this is the risk of bias for this literature review. Green is low, yellow is moderate, and red is high, and black is critical. And this is a very extensive systematic literature review because it's not including only intra-articular therapies as the previous one, it's including all MSK injection. Obviously, we are not going through this paper one by one because it's impossible. They are including all type of MSK injection. The only thing I would like you see is these red points. So all the papers with this red mean that they have a high risk of bias. So the quality from a pure methodological point of view is low. See some in green, a few in green, most in yellow, and a lot of these papers that were included in the systematic literature review in red. Just to go quickly, I recommend you read this wonderful systematic review. It's one of the best I have never read. So, at the end, taking all the conclusion of this systematic literature review performed 1 or 2 years ago, so quite recently, we can really say that the accuracy of ultrasound or imaging in general, particularly ultrasound-guided injection, of course is greater than the injections not guided by imaging, for sure, just reaching the target, either intraarticular or extraarticular. They have clearly demonstrated a greater safety, including less procedural or post-procedural pain and discomfort with ultrasound-guided injection versus conventional injections. However, so far, the impact of accurate needle placement on efficacy or other benefits, sorry, but have not been fully demonstrated. So, we can say we are clearly more accurate, we are safer, that in my opinion these two is enough, but we cannot say that we are using ultrasound more effective than not using any guidance. Possibly due to, well, methodological problems. So the papers dealing with this topic are very heterogeneous, with very different methodology, with absence, of course, of data on cost effectiveness, that is another parameter that is important. So in my opinion, and then you have to help me because I'm not sure how to design that. How is possible to design a clinical trial, a double-blind clinical trial comparing ultrasound-guided versus no guided injections? I have been 20 years thinking of that. Putting for the patients, maybe, but for you? But for you? So, to have a evidence level A maximal, as you know very well, you need randomized, double-blind clinical trials. This is what is established. So please, let me know how to develop, to create, to generate a clinical trial where the doctor and the patients are both blinded, comparing ultrasound-guided versus anatomical guided. Any idea? Yeah, but there is a single blinder, so you never will be level A of evidence. By definition, sure, this is what we have, but then is when you put the risk of bias. I mean, all these methodological things are clearly established. So for having evidence level maximal, you need double blind. So we possibly never will have that. So taking into account that is because possibly we don't have this high quality of studies that can say definitely imaging guided is more efficient than not imaging guided. Sorry, by? Exactly, is what I mean. I have 2 papers on that. In this list I showed before. And according to the systematic review, I was put in red. Risk of bias. Why? yeah, but I mean, if we are extremely methodologically, we are so wide, because it is supposed, if I am comparing with myself, when I use ultrasound, because I believe in ultrasound, this is biased in me, and I will be better. So I will destroy the patient with the blood, the other. So the argument for putting, because I asked the authors are my friends, I asked, why you put me the red? Yeah, yeah. Mm-hmm.
And that the patients are prospectively assessed, and that the methodology of assessment and the methodology that is chosen is perfectly designed and is done beforehand.
Absolutely.
You can have several trials with good quality, and then you can do an analysis.
Exactly.
And then it's even a higher level of evidence and randomized.
Right. Yeah, you guess perfectly the last point. Nevertheless, it seems clear that ultrasound guidance is maximizing accuracy and minimizing risk. And what we need is what you said, dear. We need more studies on that than to have a meta-analysis, and then we can be evidence level 1 or A. So far, we cannot say that. You know that methodologists are not ultrasound people. No. So they are applying pure, you know, they are very, in fact, a little close. My reply from the authors of this systematic review is because you are not the same doing by ultrasound, because you do better when you use ultrasound, because you believe on ultrasound, so you are biased. That methodologically can be true. So, based on all this literature review and all these conclusions that we have obtained, we can talk a little bit, just the last words about recommendations. So, looking at the EULAR recommendations for intraarticular therapies again that we published in 2021, there is only one recommendation regarding imaging of particularly ultrasound guidance. This is the number 3. Accuracy depends on the joint, route, and entry, and health professional expertise, obviously. If available, so it's a recommendation very soft. If available, and I was an author of this recommendation, but what is true is that we didn't have enough evidence to say, we'll say, other stronger recommendation. No? If available, imaging guidance, for example, ultrasound, may be used to improve accuracy. So it's a very little soft recommendation. If you go to EFSUM, in the EFSUM recommendations, we were only ultrasonographers. This is the difference. So in reality, there is a bias, and we produce this more or less simultaneously to the EULAR recommendation. EFSUM, again, is the Association of Ultrasound Societies in Europe in this case. These were our recommendations. You can read in the slide. Ultrasound guidance is much more stronger than may, be considered for fluid aspiration. Ultrasound guidance should be considered to improve the accuracy of intraarticular injections, not may, should. So the level of strength is much more. Ultrasound guidance should be used in intra-tenosynovial glucocorticoid injections for inflammatory tenosynovitis. You know why? Because there is a clinical trial. It's the only double-blind clinical trial that exists. It's for tenosynovitis. Only one, but enough to have a level of evidence 1. Ultrasound-guided therapeutic injection of the cervical lumbar spine and sacral joints may be considered as an alternative for CT or fluoroscopy. I think everybody agrees on that we need imaging guidance for a spine injection, no? I think, at least currently. The key point is some people prefer CT, some people prefer fluoroscopy, and obviously ultrasonographers prefer ultrasound that is less invasive and equally effective. And real-time ultrasound guidance should be considered for perineural injection. I think for injecting nerves, it's preferred to use imaging than other guidance, no? Okay, so I don't think this is controversial. Everybody agree on. So just the last ULR points to consider of my dear friends. You can see, again, there is also a bias because for these recommendations, participate is imaging people. So for the general ULR recommendation, we were a mix of people, clinician, imaging people, we were a few. So it's true, there is a bias according to the panel who composed the task, no? For the FSUM, all of us were ultrasonographers. And for this, most of the task panel were imaging people. So you can see the difference, no? So the first one, imaging should be preferred over over palpations to guide targeted interventional procedures at peripheral joints and periarticular structure in patients with rheumatic and musculo-skeletal diseases. So this is a very strong recommendation as compared to the other tasks, and they were more or less at the same time. So you can see how recommendations and systematic literature review, according to the orientation and who is performing that, can produce different things, no? Ultrasound should be used as the first imaging modality for interventional procedures at peripheral joints. Fluoroscopy may be used as an alternative, okay. Imaging should be preferred, again, it's very strong, over palpation to guide targeted injection at the structure encompassing peripheral nerves. Ultrasound should be preferred imaging modality, well, this is obvious. Should be used to guide targeted injection in the spine, this is obvious. Should be preferred again over palpation to targeted injection of the sacroiliac joints, obvious. And the last, that healthcare professional obviously should have experience and learn the technique. So, summarizing, in conclusion, ultrasound guidance provides, for sure, I think this is really demonstrated, more accurate, safer, and probably, maybe, more effective MSK injection, especially at sites of targets difficult to reach by external landmarks. So, very deep, very difficult. There is a need to develop a structural educational program specific for ultrasound-guided injections and possibly a competency assessment system. So you need, as for conventional injection, we need a official, or I will say standardized training and maybe a competency assessment system to perform the procedures in a really standardized and safe way, no? It is important to produce, and this is what you say, it is important and urgent to produce well-designed studies with appropriate outcomes and with a correct methodology, or at least as correct as possible, on this topic, on ultrasound-guided injection, to improve the knowledge and, of course, to gain more evidence and to can compete from a methodological point of view with others. And then I have a last warning for you. That was my case long time ago, and I have to, mainly for people who are not performing that. Once you try, you cannot go back. So careful, at least this was my case. I tried, I learned, I tried, this happened many years ago, and after that, I cannot come back. So if I don't have the possibility of guidance, I don't inject. This is a warning, and just take this as you decide. Okay, obviously this is a joke. Thank you very much.